Hello, everyone. My name is Cedra Galvin, and I work for CHA, and we are going to discuss handling medical billing cases today, June 15th. It's my mom's birthday, so keep her in mind while we're talking about this. Let's see here. How can I go? Okay, so here's the training outline for today. We're going to start by reviewing some common billing issues. And then we're going to talk about some general steps to solve various medical debt cases. We're going to go into terminology such as balance bills, surprise bills, hospital financial assistance, emergency services, and debt negotiation. And one thing you're going to hear me say probably a few times during this training is that we will have further slides on this topic, because first I'm going to try to just introduce us to these concepts, and then we're going to dive a little bit more deeply into each of these specific types of medical debt cases that you can see on your screen. So just keep that in mind. Of course, if you have a question, please feel free to ask, but I will be going back to these topics a few times just to make sure that we have plenty of examples and that we can all understand these concepts together. Okay, so first we're going to talk about common billing issues, and we're going to start with just looking at a medical bill. This is a bill for Jane Doe. Everything on here is not real, but it does give us an example of what a consumer might come to you with when they have questions about a bill that they receive. And this bill sort of presents some common causes of confusion for healthcare consumers. So one issue that might come up is that there's an unfamiliar company sending the bill to the consumer. So here it says Acme Healthcare and Acme Hospital is billing Jane Doe. But maybe Jane Doe went to a doctor named Dr. Smith, and she doesn't see Dr. Smith's name anywhere on this bill, and so she's really confused about why this random company is billing her. She doesn't understand that a lot of times hospitals will contract with doctors, or a medical group will contract with a third-party biller, and that biller is who is sending her a notice. Next, we'll see that the bill has a lot of different amounts, and the consumer is unsure about what they owe. So, like here, Jane Doe, excuse me, Jane Doe isn't maybe clear about why there are so many numbers on here, and then all of a sudden at the bottom you get to a balance due of $150. She might see total charges $1,518 and kind of freak out at that number. So oftentimes consumers don't understand like what their copay is, or that insurance has paid part of the claim. They might be confused about the amounts that they see. Next, the consumer might be receiving separate bills for the same date of service, and they're not sure which one is the final bill and what their total due is. This might be just one service that Jane received on the date of service. I mean, here we can see like she has a service date for 2 days, 7/29 to 7/30. So she probably received a lot of other services other than this service. And she's just confused, like, when are the bills going to end? What do I owe? Why are different departments within this hospital billing me? So one thing to keep in mind when you're advising a consumer is to understand how the billing process works. First, your client goes to see the doctor. Doctor submits a claim, otherwise known as a bill. These terms are interchangeable, to the insurance company. The client's insurance company reviews and pays their share if they, believe that they owe an obligation to pay. Then a client receives an explanation of benefits, also known as an EOB, from their insurance company. The client then receives a bill from the doctor's office. And if the client doesn't pay, the account may be referred to a collections agency. So every step along this process, a client may be really confused about why they're being billed or what they owe, particularly when a client receives an EOB. The client might not understand that the EOB is not a bill. Other times, the client might receive a bill from the doctor's office before they even receive an EOB, And so they don't know if the bill from the doctor's office is accurate, if it reflects what they owe after insurance is paid. So these are sort of some steps in the billing process where clients can become really confused. Common billing issues and how they come about. So first, a common billing issue is cost sharing. Maybe the the client who is an insured client owes co-payments or co-insurance and is just not familiar with these terms or disputes that these are the right amounts that they're being billed for cost sharing. Other times, a client may have received care from an out-of-network provider, and that provider or facility is billing them the full amount. In some cases, the client might not have insurance. Other cases, the client does have insurance. And so either way, this full amount might really throw them off. Or maybe they went to an out-of-network provider and their insurance did pay some of it, and so they're not being billed the full amount. They're being balance billed. Balance bills occur when an out-of-network provider bills the difference between what the provider charges and what the plan pays for the procedure. Other issues that might come up. It's not a covered benefit. The plan doesn't cover the service that the consumer received, or as oftentimes happens, the consumer uses up the benefit. For example, I had a client who didn't understand that they could only get one annual physical per year, and it was per plan year, not necessarily per calendar year. My client thought that because it was a new year, they could go get another annual physical, but because their plan year started in August and they got the physical earlier in the year, I think in June, the second annual physical was not covered because the consumer had used up his benefit. So even though that is a covered benefit, it was denied because he had used up he had exceeded the benefit limitation. Next, another common billing issue that comes around are when consumers need prior approval to get a service, or maybe they need a referral. Their plan requires an in-network referral, but they failed to do that. So some general steps to solve a medical debt case. There are three main steps for all cases. First, you want to determine if the client is insured or uninsured. Next, you want to determine the type of bill. And what we mean by this is whether it's a hospital or facility bill, or is it a provider bill? Other terms that get used are professional services or hospital services. A hospital bill will be billed by the hospital and the provider there would be the hospital itself. But a provider bill would be for a doctor. So you'll usually see a doctor's name. And that's how you can determine whether it's a hospital bill or a provider bill. Step 3, you can apply the best solution given whether the client is insured or uninsured and what kind of bill the client has received. So let's say the client is insured and has a hospital bill. So now we can start to think about our questions. First, the client is insured. So is the client being billed their cost sharing? If they're being billed their cost sharing, we know that the claim was processed through their insurance, and this is the amount that the provider thinks the client owes based on whether they have a deductible or co-pays or co-insurance. So in this case, it's important to verify that the amount due is accurate. In many cases, in most cases, it's usually accurate. So then the question is financial assistance available? Most hospitals have hospital financial assistance policies. Actually, I think pretty much every hospital in New York has one. But oftentimes these policies are only for service or for bills other than cost sharing. They're intended to protect people who maybe don't have insurance or are underinsured and don't necessarily apply to cost sharing. So it's important to ask this question, but keep in mind that a lot of hospital financial assistance policies do not cover cost sharing. Next type of situation might be after a client receives a hospital bill that this is just an unexpected bill. Like they were not expecting to receive any kind of bill at all. Maybe like not even a deductible or cost sharing bill. They weren't expecting this. So consider protections and other resources. For example, is the service an emergency service? Is the bill a surprise bill? And we will get into what surprise bills are in a second. Is financial assistance available? Or should the client negotiate or submit the bill to independent dispute resolution, which we will also cover. Next type of situation, the client is insured and has a provider bill. And by provider, we mean a doctor. So there are two kinds of situations. And I should say not just a doctor, but it could be a nurse practitioner, just any type of individual that provides healthcare services, and not necessarily a hospital or a facility. So first, again, cost sharing, verify the amount due is accurate. If it is accurate, you could try to call the provider's billing office and see whether they have financial assistance as well, or if they have a payment plan that they can offer. And we will get more into those types of strategies in a bit. The next kind of issue is an unexpected bill. So again, consider emergency services protections, which we will talk about in this presentation. Consider surprise billing law protections. And then we need to get into, after these protections, after you've evaluated them, if none of them are applicable, can the client afford to pay this bill? If not, let's talk about debt negotiation and other resources. So first, if your client is uninsured, check if your client can get retroactive coverage to cover the date of service. Some things to keep in mind are that Medicaid can go back 3 months from the date of the application. Another thing to keep in mind is emergency Medicaid, which can also go back 3 months from the date of application and but it only applies to emergency services. So either way, check and see whether your client qualifies for Medicaid or emergency Medicaid. Next, see whether they recently maybe lost insurance from their employer, or if they can obtain employer coverage that they previously had. You should consult with their HR or employer to see if they can get that employer coverage reinstated. Under COBRA, clients can select COBRA within 60 days of receiving a COBRA election notice. And this can be helpful if the date of service has already passed. If retroactive coverage is not helpful and the client is still uninsured, you can follow the next steps. So if the client is uninsured and has a hospital bill, you want to first look at hospital financial assistance. We will go into more detail on hospital financial assistance, but just keep in mind that every single hospital that has this policy will publish the criteria for eligibility, and you should check those criteria to see if the client may qualify. You should also confirm what amount the client can afford to pay, and you might consider debt negotiation if hospital financial assistance isn't an option. If the client is uninsured and has a provider bill, first ask if it's from a doctor who treated the client at a hospital. So like we said earlier, oftentimes clients who receive hospital services will get many bills. They'll get a bill from each doctor that saw them at the hospital during their inpatient stay, and they might get a hospital bill. And these bills might show up randomly. They might not be itemized or in one document. So look at the bill. If the billing provider is a doctor, then see if hospital financial assistance may apply. Not all hospital financial assistance policies will apply to services that were rendered by a doctor that are being billed because of a doctor. So it's important to just check the policy to see, and maybe you can even try to apply and try to argue that the hospital financial assistance policy should apply. You can always try that just to see if it works. You may also be able to submit a dispute under the surprise billing law, which we will discuss. Next is, if there's no hospital financial assistance available, it's important to ask what amount the client can pay so that you can engage in direct debt negotiation. Okay, so we're going to briefly talk about unexpected bills. And I couldn't really think of just one term to describe all of these types of bills, so I just labeled them unexpected bills. And these are for bills that are in amounts other than cost sharing. So oftentimes insured consumers are they're used to cost sharing, so they're expecting a copay. But what happens if they get a bill in the mail and it's an amount that seems to be something other than their cost sharing? So the types of unexpected bills I'm referring to first might be a bill for out-of-network services, and the provider is charging the full amount. The bill doesn't indicate that insurance has paid anything. Next, you might get a bill for out-of-network services where the provider charges a partial amount, and the bill might show that the health plan made a partial payment, but did not pay it in full because the provider was out of network. And the provider will then bill the difference between the provider's charge and what the plan paid. And this is known as balance billing. An example of this that I have seen that comes up pretty often are with out-of-network mental health benefits. Unfortunately, a lot of health plans do not have robust networks for mental health services. So you may see a client who gets a bill from a therapist or a psychiatrist, and let's say the provider's charge is $150, but the health plan is paid like a very unreasonably low amount, like $25, because the client happened to have a PPO and has out-of-network benefits. But their out-of-network benefits are not great, and the plan is only paying a really small amount, like $25. And then that therapist or psychiatrist may decide to bill your client for the difference. So this is what I'm talking about when I mention a bill for out-of-network services and the provider is charging a partial amount. Next, you might, unexpected surprise, a surprise bill. And this is a kind of bill that we get a lot of questions about. A lot of consumers ask us whether they come to us and ask, is this bill a surprise bill? I've heard of this thing called the New York surprise billing law, and we will get more in depth on surprise bills later on in this presentation and provide examples of what is a surprise bill and what isn't. But just generally, a surprise bill happens where an in-network provider refers a patient to an out-of-network provider or lab for covered services, or the patient is billed for care from a doctor whom they do not know or did not consent to treat them. So what should you do if your client receives an unexpected bill? First, it's important to determine why the client received the bill. What was the reason behind the amount? Oftentimes when you have a situation like the first case here, bill for out-of-network services, provider charges full amount, oftentimes this is because the provider does not have the client's accurate insurance information. Maybe your client, their insurance switched and they forgot to update their doctor's office. Or in some cases, which are very rare but happen, a client was retroactively disenrolled and just missed the letter in the mail telling them that they were found to be ineligible for their healthcare benefits or had lost their healthcare benefits. Like maybe they were laid off or something else had happened and they no longer had health insurance. In these types of situations, it's important to understand, did the provider have accurate insurance information and was the client actually insured on the date of service? Next, was the provider out of network? Is the client being balance billed? And again, we discussed earlier, balance billing means that the provider bills the client for the difference between what the insurer will pay and the provider's charges. Was the bill for emergency services? This is a really important question because there are a lot of protections that are in place for emergency services under New York law. Consumers who have fully insured health plans are completely protected from emergency services out-of-network bills. And this includes out-of-network ambulance bills, ER facility bills, ER doctor bills, and even inpatient hospitalization after an out-of-network ER visit. They are responsible for their in-network cost sharing. And we will discuss emergency services bills in more detail in a few minutes. Was the bill for non-emergency services? Now, again, we're getting at surprise billing because the next question is, if so, did the bill involve an in-network provider referring a patient to an out-of-network provider? sending the patient's labs to an out-of-network facility? Did the in-network provider engage an out-of-network provider to treat the client without the client's knowledge or consent? For example, did the client get a surgical operation and while they were under anesthesia, a doctor that they didn't know or consent to have treat them? So if you answered yes, this bill might be a surprise bill. And again, we will go into this in more detail. So again, balanced billing means the provider bills the client for the difference between what the insurer will pay and the provider's charges. There are certain protections under New York law that will apply, and there are also protections under Medicare. Once you understand the reason why the client is being balance billed, or that the client is being balance billed at all, you can determine if there are any balance billing protections that apply. For example, Medicaid enrollees cannot be balance billed. And you can click on this link to go to a Medicaid program update, and you can send a letter to the provider and just let them know that this is a Medicaid enrollee and you cannot balance bill them. Quimby enrollees also cannot be balance billed. Again, this is a great resource here, an MLN Matters article that you can use to show to the provider that they are violating Medicare billing practices by balance billing a Quimby enrollee. Commercially fully insured enrollees must read the plan's balance billing policy. Unfortunately, under New York law, there's no protection for balance billing for commercial fully insured enrollees unless the enrollee is part or is insured under an HMO. So you have to read the plan's balance billing policy to understand whether it's an HMO, or to understand whether if it's not an HMO, do they have a balance billing policy anyway? Because some plans will provide that benefit to their enrollees, even if they are not an HMO. And if you determine that the HMO policy applies, or that the client's non-HMO policy prohibits balance billing, you can use that in your advocacy. You may have to have the client file an appeal, or you can file an appeal for the client if the claim was denied on that basis. You can also file an appeal if the claim was denied for certain reasons, like lack of medical necessity or prior authorization. While we're not going to get into appeals on this training, if you go to the CHA portal, we have some trainings and resources on appeals. So next, we're going to talk more in depth about out-of-network emergency services. The recourse for consumers who receive emergency services bills apply most generally when the client is fully insured, but some self-insured clients can also benefit from certain resources. So the first step is to determine whether the bill is for emergency services. So these bills can be from an ER facility, an ER doctor, an ambulance provider, etc. They can also be for inpatient services at an out-of-network hospital immediately following an out-of-network ER visit. So in many cases, a hospital will decide to admit a patient from the emergency room, and maybe the emergency room was out of network, and generally there are a lot of protections, as we're going to get into a little bit more in detail, for out-of-network ER visits, but those can be extended to inpatient services at an out-of-network hospital if the client is under a plan that's fully insured in New York. So just confirm, is it a bill for emergency services, or did the bill immediately follow an out-of-network ER visit and was for inpatient services at the out-of-network hospital? Step 2, determine if the bill is cost sharing or if the bill is for out-of-network services. If the bill is for cost sharing, like we mentioned before, you might be able to apply for hospital financial assistance. All other bills go to step 3. So then you need to determine if the plan is fully or self-insured. If it's fully insured, the client should assign their benefits and be held harmless but for cost sharing. As we explained earlier on this slide, fully insured consumers are completely protected from emergency services out-of-network bills, but for their in-network cost sharing. If they're self-insured, first determine whether the provider complied with the disclosure requirements in Public Health Law 24, and we will discuss this later in this presentation. These are certain disclosure requirements under the law that providers must abide by, and if they do not comply, there are certain resources that your clients can take advantage of, namely independent dispute resolution, or you can have the client try to apply for hospital financial assistance. For ambulance bills, we wanted to provide a specific citation here that you could use in your advocacy. This citation allows you to advocate for consumers who are being billed or not being held harmless for ambulance bills. In the case of in-network ambulance bills, this law requires plans, fully insured plans, to hold consumers harmless. Or if the ambulance is out of network, the insurer must pay the usual, customary, and reasonable rate. However, self-insured consumers, as mentioned above, can still be billed because their plans are not subject to these state statutes, but you may be able to take advantage of the independent dispute resolution or apply for hospital financial assistance. And again, we're going to go into more detail on IDR and HFA later on. Okay, so now let's get into surprise bills. First, I want to start out by saying that understanding surprise billing is really hard. It is hard for advocates and it's hard for consumers. And it is challenging because there are so many situations that really do sound like a surprise bill, but unfortunately do not fall under the surprise bill definition in the New York surprise billing law. So we're going to walk through that definition, and we're also going to review all the various scenarios that may generate a surprise bill and also scenarios that may not. So what is a surprise bill? A bill qualifies as a surprise bill under New York law if, 1, during the course of a visit with an in-network provider, an out-of-network doctor treats the consumer. 2, an in-network doctor sends the consumer's specimen, such as urine or blood, to an out-of-network lab or a pathologist. Or 3, the consumer's health plan requires a referral and the in-network doctor referred the consumer to an out-of-network doctor. So you can see under all of these situations, the most important connection is that the consumer has to be insured. The New York surprise billing law applies to insured consumers. And so let's go over some examples of what are not surprise bills. So let's say a patient is admitted to a non-participating hospital and is treated by a non-participating provider. This is not a surprise bill because in order for something to be a surprise bill, again, during the course of a visit with an in-network provider, an out-of-network doctor treats the consumer. The first starting point has to be an in-network provider. The basic thrust of the surprise billing law is that the consumer tried to do everything they could to follow their health plan's rules. They checked to see if the provider was in network, they went to an in-network hospital, and then bam, they got stuck with the bill. That's why it's a surprise bill. It's surprising to receive a bill after you did all of your homework to make sure that you wouldn't get stuck with a huge bill that's not covered by your insurance. Of course, the exception to this is if the patient is admitted inpatient to an out-of-network hospital following an ER visit, which we discussed in the emergency services slides. So again, let's say that you have a heart attack, God forbid you have a heart attack and you go to the ER, you go to an out-of-network ER, they decide that they need to admit you, but it's still, you're still receiving care in connection with that heart attack. They admit you as inpatient, so now you're not in the ER anymore, but you are still subject to protections for emergency services if you are insured under a fully insured plan. That remains the case. However, let's just say you're admitted to a non-participating hospital for like a scheduled surgery. Let's say you're getting a C-section, and then you're treated by a non-participating provider. Let's say you scheduled the C-section. That's not a surprise bill because you didn't go to an in-network provider to begin with. Okay, moving along. A participating provider who is not a physician, for example, a speech therapist, refers the insured to a non-participating provider. So again, here, number 3, we said that the consumer's health plan, if the consumer's health plan requires a referral and the in-network doctor referred the consumer to an out-of-network doctor, then that bill qualifies as a surprise bill under New York law. So if a speech therapist refers the insured to an audiologist or some other type of provider that is not a doctor, it's not a doctor, then that would not count as a surprise bill. Next, a participating physician provides the insured with a list of local labs and recommends the client make an appointment to get blood drawn. The client goes to a lab on the list that is out of network. In this situation, the client had, again, think about the reason for the surprise bill law. It's for consumers who did all of their homework and made sure that they went to someone in network. In this situation, the client went to a lab on the list that is out of network. This one is really tricky because it seems like the physician is referring the client, but they're not, because they're providing the client with an option and the client is making the choice, not the doctor. But again, this can be really unfair to consumers because they believe that their doctor is if they're going to give them a list, they're going to give them a list that has only in-network providers on it. But that's unfortunately not always the case. And as a result of the fact that the client chose to go to this lab, and it's not that the physician just sent the lab along, it's not a case where the client went to the doctor's office, gave a urine sample, and the doctor's like, okay, we'll call you with the results, and the client walked out. It wasn't that case. Maybe this was a case where the physician said, go to a lab to get a urine sample. By the way, here's a list of labs that you can go to. In that second situation, that would not be a surprise bill. But in the first situation, it might be. The first situation where someone goes to the doctor's office, they take the urine sample at the office, and they're like, we'll call you. And the client has no control over where the physician sent that urine. Okay, next. An insured is given misinformation in a network directory or by a health plan representative that a non-participating provider is a participating provider. So unfortunately, in this case, you would think that this counts as a surprise bill because the client is trying their best to do what they can to make sure that they go in network and they don't get stuck with a huge bill. But unfortunately, even though they called their health plan or they looked up doctors in a network directory, they ended up stuck with a big bill. The provider is actually out of network. Unfortunately, this situation does not count as a surprise bill under the New York surprise billing law. But if your client is given this information by the plan, this is an issue that we've been seeing a lot and one that we are trying to advocate around to push regulators to protect consumers in these situations. If your client is given misinformation by the plan, you should submit a complaint to DFS, or if the client is insured under insured under a self-insured plan, to EBSA, and try to negotiate the debt. The New York surprise billing law. Again, so this only applies to fully insured enrollees. They are held harmless for surprise bills, and they may still be responsible for cost sharing. The New York surprise billing law does not apply to self-insured or uninsured enrollees. Again, we said earlier, the common connection between the surprise billing law definitions is that the consumer has to be insured, but not only that, they have to be insured under a fully insured New York regulated plan. However, if you come across a client who is insured under a self-insured plan or is uninsured, there is another resource that they can use. They can dispute out-of-network bills through the independent dispute resolution process, which we will discuss, or they can apply for hospital financial assistance or negotiate the debt, which we will discuss. So quick recap. The surprise billing law applies differently to fully versus self-insured plans. Fully insured plan enrollees, the employer may pay a monthly premium to an insurance company, and the insurance company assumes the risk of paying their healthcare costs. So if the employees get very sick, the insurance company loses money, As a result, fully insured plans are subject to New York law and they're under the jurisdiction of the New York Department of Financial Services. Self-insured. The employer pays its employees' healthcare costs out of its own funds, but it often hires an insurance company to administer the plan. If the employees get very sick, the employer loses money. The self-insured plans are subject to federal law, and their complaints are under the jurisdiction of the U.S. Department of Labor. So this is just a quick recap on how you can determine whether the consumer is insured under a fully insured plan or a self-insured plan. But the best way to find out is for the consumer to call their plan or check their benefits booklet, or if it's a NISO plan or a Medicaid plan, you can rest assured that it is fully insured. And again, this is really important because if the client is fully insured, they can take advantage of the surprise billing law. And if there's some type of issue along the way, maybe the surprise billing law doesn't apply because of plan misinformation, then you can submit a complaint to the Department of Financial Services. If the client is insured under a self-insured plan, the surprise billing law does not apply. If the client experienced any type of plan misinformation, you can submit the complaint to EBSA, which is an agency under the U.S. Department of Labor. So we're going to go even more into detail about how to recognize surprise bills. Earlier, we talked about situations that seem like surprise bills, but are actually not surprise bills. But now we're going to talk about bills that are in fact surprise bills. So one way to recognize whether a hospital or ambulatory care bill is a surprise bill is, after determining that the client is fully insured, you can examine whether the client went to an in-network hospital or ambulatory care center and an out-of-network doctor treats the client. And maybe one of the following is true. No in-network doctor was available. The consumer had no knowledge that the doctor was out of network, or the out-of-network doctor was needed because of unforeseen medical circumstances. So an example of this is an anesthesiologist. This is kind of the classic example. So the client calls CHOB because they received a bill from an anesthesiologist for $25,000. Some important questions to ask. How did the client come to see the anesthesiologist? Let's say the client had a scheduled surgery and the anesthesiologist was a part of that surgery. Okay, pretty self-explanatory. Next, ask yourself, was the hospital in network? Okay, yes, all right, so it seems like a surprise bill. Next, is the client getting any other bills? No, the primary surgeon had requested prior authorization, which was granted because the surgery was considered medically necessary and the surgeon was in network. So this isn't a situation of a client receiving a bill because they did not follow their health plan's rules. They went to an in-network facility and they received prior authorization before they got the surgery. So why are they getting this bill from an anesthesiologist for $25,000? The answer, well, the bill may be a surprise bill, and there are 3 scenarios that could apply. Scenario number 1, the in-network anesthesiologist that was scheduled to perform anesthesiology for this particular surgery called out sick, and there's only one anesthesiologist available, and she happened to be out of network. The second scenario, in the operating room, the anesthesiologist administered anesthesia to the client, but never informed the client that he was out of network. Maybe, the client just assumed that this person was in network and had no idea and didn't sign any kind of form or wasn't made aware of the fact that this doctor was out of network at all. The client was conscious and was aware that this person was treating them, but they didn't know that the anesthesiologist was out of network. The third scenario, the client's surgery went wrong and another, anesthesiologist was called in to help save the client's life. So in this situation, this would be an out-of-network doctor that was needed because of unforeseen medical circumstances. The next type of situation that's common are provider referral surprise bills. So here are some examples of things that might arise when you get this type of surprise bill. The client is treated by an in-network doctor. and the in-network doctor sent blood samples or specimens to an out-of-network lab, or maybe they even prescribed an out-of-network device, a heart monitor, without the client's knowledge or written consent. Or maybe the client is billed for any other services performed by an out-of-network doctor if the plan requires referrals. So this most often happens with HMOs. An HMO enrollee must be referred to in-network specialists by their PCP. If their PCP refers them out of network, it's not the client's fault. The client went to their PCP to get the referral. They followed their health plan's rules. If the PCP referred the enrollee to an out-of-network specialist, then this would be a provider referral surprise bill. Or let's say the out-of-network doctor treats the client at the in-network doctor's office during the course of the same visit. So maybe you go to your primary care doctor and you're complaining because you're having like some ear, nose, issues, and there happens to be an ENT in the same office, and your provider's like, go next door to so-and-so's office and see if they can figure out what's wrong with you. This would be a provider referral, and this person is telling you to go within the same maybe office or just down the hall, and so you think to yourself, this person must be in network, and you go to that doctor. Turns out that doctor is out of network. Another situation that might arise are surprise bills and out-of-state services. So in this situation, the client might be treated by an in-network doctor, and the in-network doctor sends blood samples, again, specimens, to an out-of-network lab or prescribes an out-of-network device, like what we talked about before. But let's say they do that and they send the samples and specimens to a lab that is out of state. And you might ask, does the surprise billing law still apply? I thought this was a bill that only applied to New York. Well, you're right, it's true. Sorry, it's a law that only applies to New York. And you're right, that's true. But if this is the case where the provider sent samples and specimens to a lab that is out of state, you might still be able to advocate for this client that the bill was a surprise bill if part of the service was performed in New York State and the out-of-state provider has a sufficient nexus with New York State. So again, part of the service must be performed in New York State. In this situation, it would be an in-network doctor that's in New York, and let's say they sent the blood samples to a lab in New Jersey or to a lab in Texas. That's the example I had here. So you might think, okay, Texas, New York State, is there a sufficient nexus? If the client is covered under an HMO or insurance policy or contract that is issued for delivery in New York and has blood drawn in New York by his or her participating physician, and then the physician sends the sample to an out-of-state lab in Texas, but let's just say that lab regularly conducts business with the New York provider. The New York provider might even have a contract with this lab. This is his go-to lab. Then the Texas lab may be subject to New York surprise billing protections because there is a nexus between that provider and New York State. So just because you have a client who has a bill where the out-of-network provider is not located in New York State doesn't mean that you cannot rely on the surprise billing law. It's just really important that part of the service was performed in New York State, the part that led to the referral, and that the out-of-state provider has a sufficient nexus with New York State. And I bolded regularly conducts business because this is the classic example of what is a sufficient nexus. And that language is the language that DFS uses when assessing whether a sufficient nexus exists, but it's obviously not the only example. It's just really going to depend. It's a case-by-case you're going to have to determine everything on a case-by-case basis. Another situation that might come up where that is a sufficient nexus is, let's say you have a border town provider. So, I'm not good with the East Coast references because I'm not from New York, I'm from Southwest Missouri, but I grew up in a border town that borders Arkansas, Oklahoma, and Kansas. And oftentimes people who live in really rural areas in Arkansas or Oklahoma might come to the hospital in my hometown in Missouri because it's the closest hospital within 60 miles. Well, let's say the New York surprise billing law is like the Arkansas surprise billing law, and that doctor routinely sends patients to this hospital in Missouri because it's the closest hospital. Well, then that surprise billing law would apply in the situation because you're sending, part of the service was performed in the state that has that law, and the out-of-state provider has a sufficient nexus with that state. Okay, so surprise billing, the physician referral example. So the client calls because they received a $3,000 bill from Quest Labs for processing blood work. One question to ask is, did Quest Labs submit the claim to insurance? If yes, then client had called Quest and they said it was denied because they were out of network, then ask yourself, was the provider who drew the labs in network? Yes, okay, it was the client's primary physician who was in network. You're getting closer to maybe it being a surprise bill. Then ask, was the client aware that the provider was sending the lab to an out-of-network facility? If the answer is no, the client was not informed and never signed any acknowledgement. What you can tell the client is that this could be a surprise bill, and the client should follow the surprise billing steps. And in this situation, which is very similar, is like, let's say it's for heart monitor equipment. Did the heart monitor provider submit the claim to insurance? Yes, and it was denied because they're out of network. Was the provider who ordered the heart monitor in network? Yes, the client's primary care physician had prescribed the device and referred them to a local hospital to pick it up. However, the provider that analyzes the data obtained by the monitor is based in Texas and is out of network. Was the client informed that the provider and device were out of network? No, and they did not give written consent. Again, you can tell the client that this bill may be a surprise bill, as long as there is a sufficient nexus between the provider in Texas and New York State. And let's just say that this primary care physician is constantly using this device, and this device's data is analyzed always in Texas. And therefore, there is a relationship there. There's a regularly conducted business relationship between the provider in New York State and this provider in Texas, because there's seems to be this constant pattern of referrals. So what can you do if a consumer receives a surprise bill? Let's say you've went through all of the exercises that we just discussed, and you're pretty positive that the consumer received a surprise bill. If your client is enrolled in a fully insured plan and you have determined that they've received a surprise bill, they should assign benefits and be held harmless but for their cost sharing. To assign benefits, the client must complete the assignment of benefits form, which is available on the DFS website, and which we have linked below. And they must submit the completed form and a copy of the bill to both the out-of-network provider and the health plan. And this form, also known as an AOB, basically allows the client to assign their health insurance benefits to their provider and instructs the plan that they must pay their provider for these services under the surprise billing law. If your client is enrolled in a self-insured plan, they're not going to be able to take advantage of the New York surprise billing law protections, as we've discussed. And in that case, you want to determine whether they complied with the disclosure requirements in PHL 24, which we will get into in a bit. And if the provider did not comply, to consider submitting a dispute to IDR. So this is what the assignment of benefits form looks like. And if you happen to forget any of the instructions here, or you happen to not have the definition of surprise billing handy, everything is on this form. And here it says that I assign my rights to payment to my provider. And here, this has to be filled out by the client. You can advise the client on how to fill it out, but they have to fill this out themselves. And this allows them to assign their health insurance benefits to the provider and direct the plan to bill the provider. And in a way, it also directs the provider to stop billing the client for these services because they fall under the surprise bill law. So now we're going to get into Public Health Law 24. And to be honest, this situation does not arise very often, and there are not that many cases where this might be the appropriate solution. And practically speaking, you may have to skip ahead to, if it's a hospital bill, to hospital financial assistance or into debt negotiation. But we wanted to provide these resources to you so that you're aware of them in this, in the event that this might be the best course of action for your client. So, if your client is uninsured or is insured under a self-insured plan and cannot take advantage of the New York surprise bill law, they can still dispute out-of-network surprise bills. And I'm putting surprise bills in quotation marks, and I'll explain why in a second. If the physician or treatment center did not properly disclose information required by Public Health Law 24. And this dispute process that they can try to access is called Independent Dispute Resolution, or IDR. So you can find online this FAQ that's a great resource on Public Health Law 24. But essentially, hospitals are required by law to make available information about their standard charges for the items and services that they provide. Hospitals are required to post health plans that they accept on their website. They're required to post a disclaimer that some doctors may not accept the same insurance as the hospital on the website, and other requirements that are here. And so these disclosure requirements act as a sort of method by which, like a hook that you can use to advocate for your client to be able to go to independent dispute resolution. Because your client must meet one of these disclosure, or excuse me, your client situation must warrant a situation under PHL 24 in order for them to be able to take advantage of independent dispute resolution. This is New York's way of kind of like trying to provide some type of surprise billing law protection to self-insured and uninsured consumers. Self-insured plans are regulated at the federal level, and there's only so much the state can do to help people who are insured under those plans. And this is kind of the state's way of trying to provide a resource to people who are insured under self-insured plans. So under Public Health Law 24, there's all of these requirements for hospitals and physicians to make sure that they're disclosing in writing or online the insurance that they accept, that they're advising their patients that they might receive a surprise bill, and doing their due diligence to notify people that patients that it's their responsibility to try to figure out whether this is going to be covered under their plan. And if hospitals and physicians don't abide by these requirements, then your client and your client gets stuck with what would otherwise be thought of as a surprise bill, or it's a bill for out-of-network services or emergency services that the client thought was going to be covered under their health plan. Then they can take advantage potentially of independent dispute resolution. So let's just say that the hospital or physician didn't meet all those disclosure requirements. They didn't tell the patient that they might get billed or that their insurance might not be accepted. The independent dispute resolution process is a state process for uninsured consumers or consumers that have employer or union self-funded coverage to dispute fees charged by out-of-network providers. And this process is only available for emergency services and surprise bills. Disputes are reviewed by an entities known as Independent Dispute Resolution Entities, or IDRE. And this is kind of the most important aspect of this, like practically for an advocate, is that there is a fee. Oh, sorry, I haven't gotten to that part yet. That's later. So there's financial risk to this. And I'm just gonna skip ahead because I just wanna make this very clear. The IDR process carries financial risk. The cost of the process is $395. And oftentimes most people don't qualify for a waiver of that fee. So if your client's bill is for, let's say, $400, it might not be worth it to go through this process. Or if you don't think that your client's going to meet the financial hardship criteria, it's a gamble because Well, the doctor may have to pay the cost of the dispute resolution if the IDRE determines that the doctor is overcharging the client. That might not be the case, and your client could be on the hook for $400. So that's just something I want to make very, very clear, because you only want to use this if, or I would advise you to only use this in situations where your client is stuck with a huge bill and you might as well try this process, and you think that you might be successful. So let's get into like some situations where it might be worth it to follow this process. So again, disputes submitted to IDRE, the IDRE will determine the fee that the provider may charge the consumer, and the fee is binding on the provider. So on the one hand, you might think this is a really good tool for my client because I want to make sure that the provider charges my client a reasonable rate, and I don't think I can achieve that through negotiation or through other hospital financial assistance or other measures. So that might be one reason. Another is that if you look at the factors that the IDRE will consider when making a determination, they're going to see the essential question for them is the fee that's being charged here reasonable? And here are the sort of factors that they use to decide whether the fee is reasonable. One, is there a gross disparity between the fee charged and the fees paid to the provider for the same services provided to other patients in healthcare plans in which the provider is not participating? Are the fees paid by the health plan to reimburse similarly qualified out-of-network providers for the same services in the same region? Basically, I mean, is this just a completely outlandish charge? Is this a charge that is just, you're charging $10,000 for a surgery that under like another health plan, you would charge $2,000? Well, in that case, it might be a really gross disparity. They'll also take into consideration other factors like the provider's training, education, experience, the complexity of the case, the patient characteristics, and the usual and customary cost of the service. So you as an advocate should also be thinking about these factors when you're deciding whether IDRE is the right solution for your client. Again, you don't want to recommend this because if you don't think it will go anywhere because of the financial risk. Of course, make your client aware that it exists, and it's up to them whether they want to do it or not, but just so you're aware of what's at stake. So this is the patient application for IDR. And one thing that we have a resources slide on later that I can share with you is to make sure that the fee is if it's actually usual and customary. And one thing you can do is go to a website called Fair Health, and we have this in the resources slide. And Fair Health is a database that contains procedure codes and rates that insurers typically pay for those procedures. So if you're asking yourself, well, how do I know whether there's a gross disparity between the fee charged by the provider and what other plans pay? You should go to that website and first get the CPT codes for the procedure at issue and plug those into the Fair Health database and try to see whether the fees are unreasonable. And again, we have a resource slide that includes that Fair Health website. So again, this is the patient application for IDR. And you'll see, it goes into my physician did not tell me this, or this. Like these are the disclosure requirements. It's making reference to the disclosure requirements under PHL 24. So you can also use this patient application as a quick cheat sheet for determining whether your client even qualifies for IDR. All right, so next let's talk about hospital financial assistance. So there are 3 steps that you want to take when you're trying to determine whether hospital financial assistance is the right step. And I want to start by just saying that hospital financial assistance should sort of be your last resort. Always try to make sure if there are other protections in place. So first, determine if the client is insured or uninsured. Second, determine the type of bill. Is it hospital or provider? Again, hospital financial assistance oftentimes only applies to hospital bills. Sometimes it will apply to provider bills as well, but you need to check the policy. Third, determine the best solution. So once you've just determined that health insurance has paid all it should and that other protections are not going to apply. So here when we say has paid all it should, we mean all it should under the New York Surprise Billing Law, under emergency services protections, and other resources, then you should apply for hospital financial assistance. So again, just really quickly, before applying for HFA, determine whether the insurance can pay or pay more, if the consumer can be held harmless. Go through the exercises that we just covered. But here's just a quick refresher slide in case you need it, just to make sure that you followed all of those steps. Again, hospital financial assistance is usually only offered to cover hospital bills. But again, this is a slide that you can use to advocate that the doctor's bill should also apply. I mean, you can say doctors are employees of the hospital. They should be subject to the hospital's financial assistance policy. Or if they're not employees of the hospital should offer discounts based on the client's approval of hospital financial assistance towards a hospital bill. Hospital financial assistance is a policy that has to be available under most hospital policies just because of the charity care requirements for hospitals in New York State. And it's important to first screen your client for eligibility for HFA. And because HFA has to be offered at most hospitals in New York State, just go to the hospital's website. Here we have New York Presbyterian's website as an example and see what the criteria are. Generally, all hospitals are going to have very similar criteria. And first will be, of course, New York State residency because of the New York State charity care law. There's no immigration or citizenship status requirement. So this is a very helpful resource for undocumented clients. Patients are usually eligible if their household income is 300% of the federal poverty or line or below, or if they can demonstrate an inability to pay. Now, some hospitals will have higher than 300%, like I think Mount Sinai, I just looked at theirs today, is 400%. So always check the hospital's policy online to make sure that your client meets those criteria. But just in general, we wanted to let you know that at a base level, New York State residency, and there's no immigration or citizenship status requirement. Okay, so hospitals are required, again, to post their summary, application, and financial assistance policy on their website. Some steps that you can take to help your client out with this is to just print the application for them, help them complete it, help them gather the required supported documentation, and help them submit the application. One thing that's important is that if the client does not meet the income eligibility requirements, but they can show an inability to pay the bill, they may want to apply for assistance anyway. And this is something that's very important right now with COVID and layoffs and the fact that, or furloughs and people being underpaid, is that their tax return from last year is not necessarily indicative of their financial situation. And so you can really make a financial hardship argument these days like much more easily than in the past. So it's very important that you shouldn't just dismiss HFA if your client truly has an inability to pay that bill. And it's important to keep in mind, and something you should tell your client, is that the hospital cannot send an account to collections while an application is pending. So some clients might be really afraid to apply for HFA because they're worried it will take a while and that interest will accrue, this will be sent to collections. But under the law, the hospital cannot send that account to collections while an application is pending. Your client will also have appeal rights if the HFA application is denied. They should have an opportunity to prove that they are unable to pay. And it's important to just advise your clients that if that were to happen, just in the meantime, to keep tabs on all of their expenses. make sure to save their Con Ed bills and their phone bills and other bills that they have, because it's very helpful to show those expenses if the HFA application is denied. Again, so just getting a little bit more into detail about the supporting documents and things that you will want your client to do everything they can to try to gather are pay stubs, proof of residency, assets test if under 150%, soft credit scoring. They can't ask for tax returns or proof of citizenship or social security number or an assets test if over 150% of federal poverty, monthly bills and expenses. They cannot ask for those things, but you can always give these things as part of your financial hardship application. So help the client appeal an HFA denial or award. So appealing denials, make sure you follow the hospital's appeal timeframe. Hospitals are going to set their own timeframes. These aren't in the law, so it's important to track this. The denial letters must detail the basis for the denial. A few words is not enough. And so this can be a grounds for appeal is that the reason was not sufficiently detailed. Another grounds for appeal is if the client was actually eligible, and you can use those documents to prove that your client was eligible. Appealing awards. The law states that a hospital can give financial assistance to clients that are above the eligibility threshold, but can demonstrate an inability to pay. So while the hospital cannot ask for this information, you can provide it. You can gather these supporting documents like monthly expenses, proof of other debts, and recent pay stubs to appeal the award and show that your client does meet that financial hardship criteria, despite the fact that they are above the eligibility threshold. And the most important thing that you can do as an advocate is to write a compelling hardship letter for your client by analyzing and taking into consideration all of their monthly debts and expenses, their financial situation, whether they've been laid off, maybe their unemployment checks aren't coming in, etc. You might have to complain to the New York State Department of Health in some cases. If the hospital continues to deny an otherwise eligible client or otherwise violates the hospital financial assistance law or their own policy, submit a complaint to the New York State Department of Health. And the link to the complaint is right here. Another thing that I would keep in mind is sometimes these hospitals can change their policies. So I would print out the policy at the time that you apply, just so you have a copy of it. Facility fees. So we just want to really quickly talk about facility fees and some strategies that you can use to reduce the cost of facility fees for your clients. First, what are facility fees? They are add-on charges from a hospital or a hospital-based provider, even if the office is outside the hospital. So what I mean by this is that sometimes you will see a bill that has a facility fee, and it's really confusing to you and your client because the client didn't go to what would be considered, a facility. They didn't go to a hospital. Why do they have to pay this fee? Maybe they just went to an urgent care center or a standalone clinic or just something that's not as gigantic as a hospital. Those entities might still add on charges known as facility fees. The fee will be listed on the EOB and on the bill. It will usually say facility fee. That's how you can identify it. And sometimes both the doctor and the hospital will charge facility fees. And this often happens after an ER visit or a surgical procedure. And many hospitals do not explain these facility fees to patients beforehand. So oftentimes you'll have a patient that went to the ER for something really simple, they thought I'll pay like my copay, I had a $300 copay or something and I'll be good. And then because they have a deductible or they have cost sharing or something, and then all of a sudden they get stuck with this $5,000 facility fee. A lot of insurance will not cover them, or if they cover them, it will apply to the deductible, and it can be a hardship for a lot of folks, especially people who didn't understand that they were going to get this fee. And again, this is not going to fall under the New York Surprise Law, billing law, even though it's just seems like out of nowhere. So how to fight back against facility fees? One is you can file a complaint with DFS, especially if the plan is just refusing to pay. You should, try to make an argument that this is covered under the client's plan, and therefore the plan must pay more than what they're paying. You can also call the provider hospital directly to negotiate or fight the facility fee and ask why the client's being charged this fee and make sure it was correctly applied. And I think one really important tip for this are coding for facility fees. And I'll just share a personal anecdote. I was able to successfully fight a facility fee by arguing that the scale of complexity that was applied was incorrectly applied. So what I mean by that is emergency room facility fees are coded on a 1 to 5 scale of complexity of care. So a 5, I believe is, yes, a 5 is the most complex type of care that you could receive at that facility. And a level 1 would be a very much less complex, like more simple situation that the hospital would be dealing with. So I went to the ER because I had a migraine and they'd never had a migraine before. And I was just in a lot of pain. I was like, I have a huge headache. That was my main complaint. And I remember one of the nurses even asked if I slept on my neck weird. Like she's kind of acting like I didn't even need to be at the ER. But again, I'd never had a migraine. I didn't really know what to do. So I went to the ER. And when I got the bill, it was coded at a level 5, which my dad is a doctor, and I asked him, what is a level 5 emergency? And he said, cardiac arrest, like a gunshot wound, like something very complex, not a migraine. So I called the hospital's billing department and I made this argument that this facility fee was outrageous because I didn't have a gunshot wound or I wasn't having a heart attack. This was just a headache, and I was given, like some really strong anti-inflammatory drugs. That's it. So you can fight these facility fees by contacting the provider directly and asking them to recode the claim and to code it at a scale of complexity that is much more appropriate. If for some reason you're not able to argue for a lower code, the next step would be to apply for hospital financial assistance. Okay, so moving on to debt negotiation. So again, these are the same steps that we discussed before. You want to determine if the client is insured or uninsured. You want to determine the type of bill, hospital or provider, and then you want to determine the best solution. Again, debt negotiation, like hospital financial assistance, is something you want to wait to start until you have evaluated every other option that we have discussed before. But once all those other options are exhausted, then you can turn to debt negotiation. And in this situation, I would also say HFA, you would want to try that before debt negotiation if it's a hospital bill or the HFA policy applies. With medical and debt negotiation, you want to first verify that the debt is valid. So what this means is, can this debt collector actually go after your client for this debt? Does your client actually owe anything? Or did the debt collector just buy this debt without investigating whether your client owes? So check the bill's date of service, the service performed, and confirm that the client received this service. And this is important. I actually, again, personal anecdote, was billed by a provider for a service I did not receive, didn't go to that doctor's office. You got sent to collections. I explained, I don't know who this doctor is, why I'm getting this bill. And they just stopped calling me immediately. They investigated it, and apparently there had been some kind of mistake. So you will be surprised. Make sure to check and see whether the client actually received this service. Next, negotiation with a provider. Is the provider a hospital or a facility? Again, you want to try to apply for HFA first. Ask if the provider has a policy on bill reduction. Even if there's no HFA option, maybe it's not even a hospital bill, Most providers that we have come across will offer some type of bill reduction or discount, patient discount. Even if your client has insurance, sometimes the provider will apply their uninsured patient discount. So ask if that provider has that policy and if they will apply it. Check the fair market price for the service performed. And so again, earlier I had mentioned Fair Health as a resource that you can use. And so here's a website for Fair Health. The fair market price is the amount that providers regularly charge in the area, and Fair Health has a great database that you can use to find the fair market price. It's important to have the procedure codes handy so that you can do this check. So then when you're actually negotiating with the provider, tell them about the cost of care that was received, explain the client situation, and ask for a discount. If the client is living on a fixed income or a low income, or if there are other factors that make it difficult to pay, then write a letter of financial hardship. And actually in our CHA resources portal, we have an example letter, if you'd like to look there, as to sort of start out your template of how to make that letter to the provider. Negotiation with the debt collector. It's important to keep in mind that debtors have rights. You have a right to written verification of the debt. You have a right to notice. You have a right to not be harassed. And there's limitations on how medical debt collectors can contact debtors. We don't have time to go into all of these sort of protections today, but to sort of see what resources are available for clients that are receiving calls from collectors for medical debt, or any other kind of debt for that matter, we advise you to check out Law Help, and we've provided a link here for resources that you can use in the event that your client is receiving notices from a debt collector. If you believe that the debt collector is violating any of these practices mentioned above, or if the other practices, prohibited practices that are included on the Law Help website, then please feel free to call CHA for technical assistance. Apply for HFA even if the bill is with the debt collector and not the hospital, because the debt collector is bound by HFA. And this is important. A lot of times people think that just because the debt is with the collector and not the hospital, that HFA is no longer an option, but this is not the case. So if you've determined that your client will have to pay an amount that she cannot afford, based on all the, after following all of the steps that we've just gone over, then try to negotiate. Again, ask if the provider has a policy, a financial assistance policy, write a compelling hardship letter and provide supporting documents. If the client is a long-term patient of the practice, mention this. It's the same as, making a complaint to other types of businesses and explaining your experience with them if you have had a long-term relationship with them. Always ask your client what she can realistically afford to pay. This is very important. You should not be negotiating on behalf of your client without their consent and without their full knowledge of what exactly you are offering. So use that, ask your client that question, and then use that information to anchor your negotiations. My advice is to come up with a very low number to start, because you're just starting negotiation and it's only going to go up from there. And make sure your client is aware of that, aware of the fact that even if your client, let's say the most they can pay is 500, just say, let's start by offering 200, but just so you know, it's probably going to go up, and let me know, what your limits are, what you can afford. One thing that's been pretty successful for CHA is offering a lesser payment in one lump sum. Because often debt collectors just want to close an account. They don't want open accounts, and it eases their mind if they can just close it with a one lump sum payment instead of having to track a payment plan. So if your client is in the position of being able to offer one lump sum payment, then consider that. But obviously, this is all dependent on whether your client can really realistically afford to pay. It's important to ask your client, if they're going to offer a lump sum, where are they going to get this money from? And if they're hesitant or they're not sure, then you don't really want to push for that, because you don't want your client to then default on this debt as well. So it's really important to only do the lump sum if your client is confident that they can pay it and pay it within the time frame that the parties will agree to. If the client cannot afford to pay in a lump sum, it's important to then try to set up a payment plan. Again, make sure a client can truly afford the amount that they agree to pay. Review any settlement agreements carefully and make sure your client understands the terms. If the settlement agreement does not provide protections if the client defaults, then do not sign that agreement. You want to make sure that the settlement agreement has a clause that if the client defaults, the creditor will give her written notice and not take any further action for 30 days. And this gives your client an opportunity to, rectify a situation. Maybe a check came in late, or just some type of issue that was out of their control. This allows your client to have some protection in the event that something goes wrong and this particular creditor is very aggressive. So here are some resources that you can use. We have a lot of resources on the CHOP portal for debt negotiation. And so here you can see all of the different resources, billing documents, HFA assistance. We have some sample letters, just various resources that you can rely on if you need more information apart from what's in this training. And with that, I will open it up to questions. Thank you.
Thanks, Idra. Are there any questions? Taking a look, I do see Elizabeth Hoyt wrote, if you want a New York example of a border town, you could use Guthrie Robert Packer Hospital in Sayre, Pennsylvania. Sayre is just barely over the southern border of New York. Folks who live closer to Robert Packer than to Cayuga Medical Center in Ithaca might get referred over the border instead. So, thanks.
Thank you, Elizabeth. I really appreciate that. Even though I lived in New York for 8 years, I'm not as familiar with where some of these border issues are. So I really appreciate that. Thank you.
Krista has a question. She wrote, I have a client who I just started working with, so I'm still gathering the details, but the family has a child who has a CHIP plan and was admitted into an in-network hospital, but they were told they needed to go to another hospital, which was out of state. And Krista is assuming that that will be out of network. If the in-network hospital told them they needed to go to this specific out-of-network hospital, would that be considered a surprise bill?
That's an interesting question. In this situation, if no surprise billing law situations are just that, they're a surprise. The patient usually doesn't consent or have knowledge of the referral. And, so an out-of-state situation that would apply would be, if someone's in the ER and is at a hospital in, on the border of New York and Pennsylvania, as Elizabeth was talking about, and they need to be airlifted and sent to a hospital out of state or something because that is the closest hospital, and the patient is under anesthesia or sorry, under unconscious and doesn't have any awareness that this is happening. Like that would be a sort of classic surprise bill situation. A situation where a hospital is sort of giving this forewarning and saying, you should send this person here, and they're able to consent or not consent to that transfer is a different situation. And I would say most likely would not fall under the surprise billing law. In that case, what I would say is that you should really talk to the plan about whether it's possible for this client to go to that hospital. In some cases, a plan will agree to a case agreement. And I don't know if Diane's listening, if she has other advice, but one thing you could do is try to enter into a single case agreement to see if the plan will cover that hospital if the hospital's out of network.
Yeah. Hi, everyone. This is Diane. I agree with Cedra. I think that is not a surprise bill. And the client, if she's in CHIP, is in an HMO. So she's in a plan in which they have to provide her with an adequate network. And if there's a special provider that her doctors or that the in-network hospital thinks she needs that's out of network, she'd need to get that prior authorized. And she's, of course, entitled as an HMO enrollee to an out-of-network authorization for a provider or hospital stay if her network is inadequate. So it's the in-network physicians and doctors at the in-network hospital that need to contact her plan and request prior authorization for this out-of-network hospital. It sounds like there's something, some very specific medical care that she needs, and so it's got to be the plan that determines that she needs that out-of-state hospital. It can't be the in-network hospital itself. It has to be the plan. Let me know if you need help, getting that authorization, because that would be a utilization review authorization where if the plan says no, she has appeal rights to establish that it is actually medically necessary for her to go out of network. But absolutely not a surprise. So she should not she should not move to that hospital without authorization and wait for a bill to come in the mail.
Great, thank you.
And I just want to say, if any, people might have more questions that we're happy to field, but we can help identify surprise billing issues and walk folks through the best recourse for clients depending upon the kind of bill they get and the kind of insurance they have. Because, this is the kind of, I do this all the time, every day. I supervise folks who deal with surprise bills every day, and I still have to refer back to my one pager and look at my training, and so it's difficult to know which ones actually qualify as a surprise, and then if they don't qualify as a surprise, what the heck to do with them.
Thanks, Diane, and thanks, Cedra. Are there any other questions before we end? Oh, I do see hands raised. Okay. No more questions? Someone put their hand down. All right, well, I guess that concludes. Oh, wait, Marge. Yes. Marge, I unmuted you.
Thank you. Okay, so this has got nothing to do with surprise bills. How's that? This has to do with cost sharing. And my question to you is going to be, what do you think is the next step I should take? Client is in a Medicare Advantage plan. He's in a dual, I think it's Univera Healthcare, dual health or something like that. Goes into the emergency room. The local hospital, which is also a Medicaid provider here in Erie County, sends the bill into Medicare, gets their Medicare payment, and then bills the client for the cost sharing. Client sends the bill back to the hospital and says, I'm also on Medicaid. Hospital does nothing after a couple of attempts, sends bill to collection. I get involved. I stop the bill collection. I got it off in abeyance until we get the problem resolved. So since there's a dispute, they're not collecting. But I contact the hospital in writing and say, look it, this is a dual plan. He's Medicare and Medicaid. And I would strongly suggest that you resubmit the bill back to United Healthcare Dual for the Medicaid balance and do that by June 1st. So June 1st comes and goes and I hear nothing from him. So the last thing I did was I wrote a letter to United Healthcare saying, look, you have a responsibility to make sure that your providers bill people appropriately. And this guy is Medicare and Medicaid, and your provider here in Erie County sent it to Medicare and got the Medicare portion of the bill, but he also sent the balance to the client for the Medicaid portion of the bill. And you need to instruct your provider of services here that they have to bill for his Medicaid portion of the bill. And of course, I haven't heard anything from them either.
Hi, Marge, it's Diane. Yeah, so I feel like we see this pretty often too. There's these kind of like dual plans that they call themselves dual plans, but sometimes, you know, you don't have to be a full dual, you just have to be on Quimby, or you have to have some level of the Medicare savings program. So it's confusing. Because a lot of times the plan's customer service reps don't know what level of the subsidy the client has and how they should be protected. So I would say, you know, two things. One thing is, oftentimes, which I'm sure you know this well, Medicaid won't pay as secondary after Medicare pays it's something like if the amount that Medicare pays is more than what Medicaid would kick in. And that leaves would potentially lead to a balance billing issue. And then the other issue would be if the client doesn't have Quimby as well, even if they're a full dual, to take advantage of the Quimby balance billing protection, they need to also be on the Medicare Savings Program Quimby. But I think the way to get the best answer about what this, if this was my case, and I often give this advice for helpline folks who are trying to solve Medicare Advantage, various tiers, problems with various tiers of a dual plan, is to try to loop MRC in and see if they can tell you what this specific plan should cover, and then intercede with this specific plan.
Already been the Medicare.
Do you know if he has Quimby? I'm sorry.
No, I don't know whether he has Quimby. I just know that he's a full dual. He has both Medicaid and Medicare.
Yeah, so that might be the issue, or it might just be that Medicaid is going to pay no more because they don't pay anymore, and then it's just about fighting with the hospital to hold him harmless. But
I don't understand the Quimby. I mean, I understand the Quimby thing separately, but if he's full Medicaid, okay. So I understand the cost capping. I get what you're saying about the cost capping, but if there is no cost capping, all right, regardless of whether he's a Quimby or not, Medicaid should be picking up the balance of this bill. I mean, if there's cost capping, then Quimby would definitely protect him. But if there's no cost capping, why isn't Medicaid picking up the balance?
I don't know. That's the only thing I can think of.
I mean, other than somebody not realizing what's going on. And that's why I keep on sending letters to people saying, bill. And nobody's come back and said to me, there's a cost capping issue. Medicaid isn't going to pay anymore because we would cover what Medicaid would pay for anyhow.
Right.
And even if he, like I said, even if he's not a Quimby, somebody should be coming back and saying to me, well, he doesn't have some kind of protections. He's not being covered by Medicaid for this or not. I'm not even getting that much of an answer. All right. I'm not getting anything from anybody, which is why I went to Univera themselves and said, hey, this is your supplier. You got the contract. How come you're not making sure that they're billing my client correctly? And I'm not even hearing from Univera. Nobody wants to talk to me.
I was going to ask what they say, because a lot of times on the helpline, we get calls from, the provider will say, or the hospital will say, well, this is what the plan told us the cost sharing is. So that's why we're going,
no, I'm not even getting
Yeah, so I think it's a good idea to get Univera on the hook.
Hi, Diane and Marge. So
like I said,
A couple of people responded, Erica and Hanson from Legal Aid and Rebecca Reedman from Law New York, and they both suggest filing a complaint with the Office of Medicaid Inspector General, OMIG, for illegal balance billing. They specifically have a unit which investigate balance billing. So maybe you can try that route.
All right, yeah. I mean, what the heck? I can write
Can we
a-
send around that information? I feel like we need that as internally as well.
Yeah, we sent it around a few times with the chat updates, but we can send it again. Sure.
Sure. Thank you.
I mean, this could be something as simple as right now, I'm not getting a response because of COVID. I mean, everything is kind of up in the air and things could have gotten dropped between the cracks. But this guy's trying to try to resolve the bill himself for about a year now. So I don't know why no answers have come back to him. And he disputed the bill. And then, of course, they took it out of dispute. And then I got back involved. And when I disputed the bill, everything kind of sort of stopped, which I'm hoping is somewhat good. But the letter that I got back from the billing company was, as far as we're concerned, he still owes the $80.
Yeah, it's frustrating that they are billing folks during COVID, but not answering the phone about
Why they're billing.
exactly. And yeah. But yeah, if he's been trying to resolve it for a year, it sounds like a complaint is the right thing to do. But I would also
and
follow up with a plan to complain, file a grievance with them about their in-network provider.
Right. I will also talk to him about Quimby because I can't hurt anyhow,
Right, he's fully eligible. It's only an extra protection for him.
Yeah. I mean, he's not going to lose anything by applying for it. And if there's any additional problems, hidden problems, then Quimby might, pop in and take care of them. But all right, I like that illegal balance billing, file a complaint. If you can get me that information, that would be great. That answers my question.
Great. We'll send that to you and to everyone.
You.
Are there any other questions? Okay. Well, thank you, Cedra, for presenting this information. And thank you all for joining us today. This completes our first day of the June intensive, and we'll see you tomorrow. Thank you, everyone.
Okay, bye-bye.
Thank you.
Thank you. Bye.
Bye.